our last three speakers will be coming up and will be fielding questions from the participants. I know everyone is itching with questions. Am I with you? Okay, we should move this session since we don't have questions. Okay, we have questions. So I'll be bringing on our last three speakers. Please, let's make welcome Dr. Abubakar Umar, Fatima Balarabe, and Tolulope. Thank you, please. We'll be starting with some questions that are unanswered. The participants, a quick one for the three of you. So, in general, what do you like about your organization's intervention? Let me start with you, Abubakar. What do you like about your Tiamaka project intervention?
Yeah, I think at the moment, I think there are a few things to like. I think the most obvious thing that we really like about ourselves is how we can easily make determinations, and how we have really absorbed like the EA mindset like so much into our community. And this is evidenced by what I said earlier, that we are able to pivot from a program or a project that we realize is less cost effective than treating children with severe acute malnutrition. And I think that is something that I really like. Like I said, if going out of that door today, I realize that what we are doing is not as cost effective as other ideas that will be generated in this room, I'm happy to do it. And I think that is something that I really like so much about ourselves, that we are not doing things because our heart says that we should do it. We are more dictated by how, the evidence and how much cost effective and how much impactful, whatever we do translate to the real world.
Great. What do you like about FEM's intervention? Why are you even working with FEM? So why?
Quite a lot of things, but I'll keep it short. The first is our reach in terms of our intervention. We chose the radio because first, radio is cost effective. And by going through the radio, we can actually reach a whole lot of people. I mean, we could have decided to go other routes. They'll probably be reaching lesser number of people. But with the radio, we're spending lesser amounts to reach a larger amount of people. And that is really great for me. And another thing is the rigorous process we go through for our research. So we work so much with evidence. I mean, we can just sit and say, oh, we know reasons why people don't take contraceptives. It's because they think it causes this, because it causes that. Some of these things are known and generic, but we don't just work with assumptions. For every region we go into, we go through rigorous research, and believe me when I say this, we want to know the peculiarities for all regions. We don't even generalize that. In Nigeria, that's what everybody says. No, we want the evidence, we want the data to speak for us, and based on that, we are able to tailor the messages per location. So what we bring out in the north is different from what we bring out in the southeast, is different from what we put our campaigns in the southwest. So we conduct research in each of this location, and so we have our evidence to back our intervention.
Yeah, so you answered one of the questions that I had in mind, and if you go to the hinterlands, not everyone have this device. So do you also do like community field work? You don't do that?
We don't do community, radio. And I think almost everyone listens to radio. Even the nomadic, if there's something you'd find with them, is the radio.
Yeah.
I think that has been proven. Yes, and there's a lot of research to back that up where we would have the information to tell you the amount of people you can actually reach through radio. Maybe not everybody, but in terms of percentage, even if you go into the community, how much of communities can you reach in Nigeria? A lot of organizations are, localized in the communities. Okay, maybe we're working in this state and we're in this number of LGAs. But with your radio, you don't need to walk into particular communities. You'd actually reach more people with radio than going into the communities.
All right, thank you.
Yeah.
So Fatima, why Lafia?
Okay.
What do you like about Lafia's intervention?
Okay. To me, working with Lafia is my passion in action. And part of it is that it's community-oriented. And it's one of the things that makes it cost-effective. We are working in the community. We are providing services in the community. When I say community, I mean including the facilities and going in depth in the rural areas, providing services there, making impact, changes, clearing misconception. This is one of the things I like generally about Lafia Nigeria and working there. Thank you.
You know, when you mention communities, rural areas, in my mind, I think projects in such areas, when you mention cost-effective and rural community in the same sentence, I'm like, because doing projects in these areas would cost you much than in urban areas, my sense. So how do you come about using cost-effective measures in your projects?
Okay, one of the things is that we are a small team as Lafia Nigeria.
Okay.
Our human resource are mostly derived, as I kept on mentioning, from the existing structure. So it means while engaging staff and volunteers, we leverage on those living in those particular, within particular geographical settlement we are working with, and that's definitely being cost effective. And also, majorly, for example, in Jigawa, I work with 45 Lafia sisters across 27 LGAs, having 45 healthcare facilities and covering the communities. They are basically situated there in the communities, and they are being provided with a little amount of stipend because they are already...
I was actually going to ask that.
Yes, they are already working with the state government. So we don't spend much there. We spend more in procuring the commodities we distribute to the end users, which makes a large impact. And that's
so
it.
I believe you're going to be encountering challenges doing this. So what are the challenges impacting your work currently? Can you mention one, two?
One of the challenges, as asked by one of the participants here, is definitely engaging with the community stakeholders, local stakeholders, having community and traditional leaders, religious leaders, and other gatekeepers. It's still a bit of work working with them currently to clear some misconceptions and establish ideologies that are already there for centuries. So this is one of the challenges. But having other organizations engaging in sensitization and the government itself eases most of our work.
Okay, so the government even also helps. Abubakar said they are here, and he doesn't want to say certain things, and now you're complimenting them. So, definitely. Government actors, if you're here, here's a compliment for you, so that you don't come after Abubakar. So, Tolu, I know FEM also has challenges impacting its work. So you want to share with us?
Yes, so aside from where she kind of stopped, I think the challenges with stakeholder management is almost a staple in this sector, but somehow we find a way to navigate, especially working with government. Not a challenge like that, but there are competing priorities, okay? Sometimes this is where their priority is, and in this sector, we have timelines, we have work plan, we want to do this, and sometimes it's not just their focus per time, and you just have to do all you can to get a buy-in and to work with your timeline, because time is of essence, and sometimes that urgency that you have is probably not just there on their end. But yeah, what are we doing to navigate this? We keep working together, carrying them along as much as we can. And another thing for us is stockouts. We work in the demand generation space. So I think I mentioned during my talk earlier, we are advocating for demand. And then what happens when you're pushing for the demand and they go to the facilities and there is stockout? It's counterproductive. Okay, and what we are doing to also navigate that is we're trying to now identify other organizations that we can sort of collaborate with, which is a work in progress, to ensure that while we work on the demand side of things, they're also doing their bits in the supply side. And together, because I believe we have a common goal, we are pushing demand so that people can request for contraceptives, Some other organizations are working in the supply side so that there is available commodities at the facilities. And together, our common goal is to ensure that women take up contraceptives, they're able to space their pregnancies, and we achieve that reduction in maternal mortality. So that's a key one.
I heard competing priorities. So how do you solve that? Do you solve it by the one that is most urgent or the one that is most important? Or how do you?
Okay, no, so when I said competing priorities, I was talking on the side of the stakeholder.
Okay.
Right, like they have competing priorities.
Okay.
And so when you bring, for instance, you bring your program, we want to do this, they have like 4, 10 other things that they also want to do. And you know that for organizations, we have a work plan, we have timelines. Oh, we want to achieve this by this date. We want to achieve this by that time. So I was speaking on the end of the stakeholder.
So the priority is yours against theirs.
Well, not against, but we look for a way to synergize to ensure that. So that's why stakeholder management is really very important, okay? You keep doing the talk, having engagements, it's like lobbying and whatever you want to call
lobbying,
it.
that's what it is. So Abubakar, so tell us, Dr. Abubakar.
I think for us is, the most obvious thing, treatment for acute malnutrition is resource intensive. Is 100 US dollars per child. If you are treating 5,000 children, you're already in the $500,000 US mark. That's like crazy. Yeah, and you have up 2.2 million cases. So if you multiply that by like 100 every year, that's quite intensive. Yeah. So and that is why at Timaka we are always looking at ways to bid down the price, just so that we will be able to reach a lot of these children. In Gombe State alone, there are about 4,000 to 5,000 cases every year. If you multiply that by 100, that's 450,000 US dollars every year in Gombe State alone. And if you go to the Bay States, Borno, Adamawa, and Yobe, the story is completely different. So it's highly capital intensive. So finding ways to reduce the cost is the most challenging thing for us. And
I was going to ask when you were presenting, how do you deal with relapse cases? In addition to that, is there a relapse case you had that was most challenging, and what did you do?
So the good thing about treatment is that any kid that stays longer than 13 weeks in the program is termed as a non-responder. So basically, whatever you do, that child is not gonna, recover. So at the 13th week, we just exempt them from the program, and there's not much we could do about it. So currently, we are running.
You exit them from the program. You don't refer them.
So we could advise them to go to a pediatrician, see a pediatrician, kind of thing. But we are to some extent confident that that problem is not nutritionally related.
Okay.
So in terms of relapse, we're currently running a relapse study. So we are following up some of our discharge or recovered cases over 6 months to see, just so that we get a precise figure for how much of these children relapsed. So at the moment, the only thing we do for them, if we find a relapse case, we just re-enroll them into the program. There's not much we could do about it, unfortunately.
So if you were to start all over again, if you were to start the Tamaka project all over again, are there things you think you won't do or you will do?
So I think the framework, and the model that we have, I think we have to some extent established that it works, which is good. But I think in terms of what we will have maybe done differently, I think we will have pushed for more government involvement, into the program. Okay. So I think now that we're already on the ground, kind of doing direct treatment without involving the government, it's a bit difficult to go back and say we really need your help, because the simple answer we get is that you guys are doing okay. You kind of don't need us. So I think it's something maybe that we'll have kind of dragged on a bit, hesitate and make sure that the government is fully in the picture and is willing to volunteer, and commit, to the cause.
Okay, so Tolu, at FEM, Are there changes you see firm making in the future with regards to the projects you're undertaking? As to either, is there something you want to stop or you want to start?
Okay, so I can't say explicitly if we want to stop things, but of course, as we grow, I think one major thing that we've learned, okay, as we grow that would keep doing better is that activities actually take longer as the organization grows. And this is what I mean. We started lean in just one state, so it's easier to get things done because you have fewer third parties also involved. As we are growing and our scope of implementation is also growing, we found out that it's more difficult to keep up with set timelines. So
I
it's
was
more
going
like
to ask that. So
aligning
your
with,
timeline, is there a timeline and it's
yeah,
like,
aligning with reality. So for instance, our RCT, which I spoke about, randomized controlled trial, ideally should have started, I think, about 3 or 4 months ago, based on the timeline. But of course, as more third parties are involved, because it now goes beyond just the core organization. So we want to do RCT, we want to put up transistors in certain locations in different states. You need to find where to put it. We have external engineers we are working with who are not even part of the organization. So you just find out that as you grow and your scope of implementation is also growing and more third parties are getting to work with you, you need to be more realistic with your timelines, and you need to actually give time for all those little delays so that you're not disappointed or you feel you're lagging behind. That is one major thing we have learned, and we would factor it into, new implementations going forward.
okay, so this is for the three of you now. What advice do you have for anyone who has a health intervention? What are loopholes you would advise them to watch out for?
Okay, loopholes. First off, get your stakeholders on board right from right from when you want to start, from concept, right? Once you have your concept, you're sure of what you want to do, get your stakeholders on board right from the very beginning. Don't start out first before going back to get them on board. That would help you to achieve things faster, because no matter where you want to implement, you need your stakeholders to work with you. Otherwise, your project might fail. They have so much influence on the success of projects in virtually every region and location in Nigeria. So that is one key thing I would say, that no matter the nature of your implementation, you're going to be working with people external from your organization. So get them on board, let them be a part of it. So it's doing with them and not doing for them. It gives them a different sense of ownership when they see that you're doing this with them, other than you're just doing it for them. So whatever it is you're implementing, whatever your intervention is, identify your stakeholders early on and get the buy-in you need.
Thank you, Tolu. Thank you, Tolu. Fatima, so what would you say to anyone who wants to start a health intervention project? What would be your, hey, look out for this, look out for that?
Okay, as Tolu mentioned, one of it is engaging the stakeholders from the onset, having a strong partnership and collaboration with other existing or implementing partners as well. That's what I want to add to what she said. Then also, after identifying a problem to work on, I advise that organizations or programs should focus more on making impact by being cost effective. Yes. For example, rather than spending much of the resources, for example, this is just an example, in holding meetings in some places, that should be focused on the program implementation itself.
Okay.
Program implementation. For example, I don't know how to link this, but let me link it up with what we do.
Okay.
Rather than having a large team, we have a small team of persons, which I believe are highly experienced and dedicated. Then focusing on program implementation means that we divert these small resources in saving lives.
Okay.
Saving lives by using these resources to make impact in the lives of persons we work with.
Great.
So that's
Abubakar, you want to share?
Of course. So I think the biggest loophole, I think, is I think we tend to lay back on traditional practices. So, an example would be in the treatment, say, of acute malnutrition or any of the, interventions, that have been, sold here. If you look at them, some of them are like novel ideas. Some of them are like new approach, to how things, should be done. And I think that is the way we could explore, very cost-effective means, of doing, these things. So like at Temaka, we run a lot of like, studies, come up with like new ideas. And one of the things that we do in like the complementary feeding or in the reduced dose, RUTF to treat the severe cases. These are kind of like novel ideas that have not been tried. And I think that is like the biggest, big hole. An idea that has been existing for the last 100 years is something that we still want to like promote, which might be, very expensive. I mean, like FARM, are there like other NGOs or other, innovations similar to the radio transmission, high intensity, what do you call it? I mean, these are like kind of like novel ideas, or even with Lifea. You get the Sienna press very cheap, self-administered by a caregiver. So I think that is like the biggest, kind of like, loophole, I would say. I think we need to go out there, explore other means of doing these things, in the best possible way. Because I believe there are a lot of changes that we could make to the traditional, practices that could go, a long way in ensuring that we live, we reach, more lives.
Yeah, great. Thank you. Thank you so much. So over to participants.
Okay, thank you, our presenters. And my name is Jebin Yunusa. I'm from Sokoto State. My question goes to Sister Fatima. Regarding your project in Sokoto State, I want to know how many local government or LGAs have you covered? Because at the rate of numbers of women that are under lack of contraceptive use is at 29%. And still yet, we are still having children that are giving birth to underage girls in schools. So I want to know, is it all the 23 LGAs are you covering in Sokoto or just few? Thank you.
Okay, thank you. Currently in Sokoto, as you already know, most of the local government are security compromised areas, and we started implementation in March this year. So currently we are covering 6 local governments. We are covering 6 local governments, Wamako, Gada, and some other local governments as well. Looking forward and exploring more options to see how we can get to reach out to women who need the services in the security compromised areas currently. Thank you.
Okay, so my question is, I was not around when Mrs. Tolu was giving a presentation, but for the Lafia, I know she talks about contraceptives, and I think you're also talking about contraceptive, right? So both of you are also in the northern region, right? Okay,
well,
so I want to know what's the difference between what you are doing, what makes yours different from what she's doing, or are you guys doing the same thing at the same region? Is that not a repetition of, what you guys are doing? Thank you.
Okay, so I think it's about coverage area, okay? We are not just in the north. We are in the north, southwest, and southeast, but you said you missed the session. We are in Ogun State, we are in Ondo State, and also in Oyo State. That's for FEM. And in the southeast, we are in Abia, Anambra, and Enugu. Yes, in the north, we don't even work in the same states as she does. Just like, you have WHO working in a couple of states, UNICEF is also working, UNFPA, we're not doing the same thing, or let me say different modes of implementation. We are on the radio, and they are in the community. eventually we may have similar goal we want to achieve. We are on the radio creating demand. We are putting out campaigns, accurate, compelling information about contraceptives so that we can take away the bias and misconceptions.
Of course. So as she mentioned, we have, even if we work in the same state, because they are currently working in Kano State, and we'll roll out Kano State this month. But although our goals are the same, but our approaches, should I call it approach, is different. They are more of sensitization and awareness creation while we do that, and we also supply commodities. So that's the basic difference. We supply commodities, they do demand creation. So, and we are supplying. Thank you.
Okay, thank you. Good morning, everyone. My question is to Fatima. I would like to ask the difficult question because I'm aware that family planning is not all about contraception. And I'm also aware that one man can impregnate 30 women in one day, if possible. But a woman can carry a baby for 9 months, right? So I want to know, because I believe that you are already working with other organizations in the region where you're working. Are you also, the Lafayette Sisters, are they also sharing information about family planning with men, or are you just focused on contraception and women? And also, another question I have is, I don't know how many women here are on contraceptions, but I can tell you that there are also challenges when you take some of these medications or injections, and you talked about, I think, 4 doses of injections or something. So what are some of the challenges in those medication you are distributing? Because I want us to answer the difficult questions as well. The Agenda 2063 of the African Union is looking towards an abundant Africa of healthy women. So if this contraception we're talking about is not actually going to affect population explosion, because it's said that women under 35, now, let me say our generation, if some of us are under 35 here, our generation is not planning on having more than 2-3 kids. And it is also said that Nigeria has enough resources to carry the people. It's just that we have leaders that are being wasteful. So how do you manage this information? And then what are the information you are giving these women in terms of health risks in taking contraceptions? Thank you.
Thank you very much for this question. And as I mentioned over and over again, these Lafayette Sisters are already healthcare providers. So they are trained from school on that, and additionally we train them on counseling and administration of this particular contraceptive I mentioned. In Lafayette, Nigeria, we distribute a single method called DMPASC Sayana Press, which has zero or none, side effects. It is an injectable, easy injectable method that's being used for the period of 3 months. Although nothing comes without risk, as you mentioned, but this is it, and its efficacy is also ascertained. So that's why we are focusing on that. There are several family planning methods. We work with other implementing partners, specifically MSI, purposely for linkage for women, because we provide counseling services, tell them the benefits and the possible risks that might come as a result of using this, although I mentioned we have zero negative effects. And women in this that we reach out to in these communities, we do not enforce the use of the particular family planning commodity we use. Our Lafayette Sisters will, while counseling, tell them the variety of family planning methods. Don't forget that we also provide information, because as I mentioned from my presentation, 35% of the women we reached out to are first-time users. They either have no prior knowledge of this family planning, or they are afraid to know more about it due to the misconceptions and the stigma attached to that, especially in the areas we worked with. So they are aware of this, and as I mentioned, challenges comes up, and we can't eliminate that, but it's in a minimal bearance. Thank you. Am I clear?
If I can add to it quickly, she also asked about male involvement. I mean, that's a phenomenon that's been around for a while. We know that the men have to be a part of it because the man and the woman make the baby, not just the woman. And a lot of women, depending on their level of agency, cannot make these decisions on their own, okay? They need to speak with their husband. I mean, I'm a midwife as well, even though I'm not practicing, and I'm an FP provider. So I've seen experiences. I've seen a situation where a man actually beat his wife to the facility because she had taken up contraceptive and pulled out the device from her and beat her to the facility. You know, things like this keeps reinforcing and letting us know that we need to put in more effort. But we also know that in this part of the world where we are, a lot of times, men tend to believe that issues of pregnancy and things are left to the women, like, that's your own area, so go and sort it. And that's why we need to do more in our collective efforts to bring the men. And so for us at FEM, our campaigns do not just address the women. When I was making my talk, everything was about women and men. In fact, we target families because the men have to be a part of it. And of course, when you look at part of the drivers why people take up family planning, economic reasons, you want to send your children to school and you don't want to have too many because you probably can't afford it. The men are responsible for these things. So in a way, they also just see the reasons based on how you put out the messages for them to say that, okay, it also helps in lifting away financial burdens and responsibilities. And with side effects, part of the barriers that we've seen at FEM is fear of side effects. I call it fear because a lot of times the reality isn't even so much about the side effects, but the fear you have. Paracetamol does have side effects, right? But we still use paracetamol. Our anti-malarials also have side effects, and we still use them. So that's the same way we need to look at contraceptives. The side effects are there, but they are manageable and they are not dangerous. And most of the time, after a while, because it's new to the body, it leaves after a few months. But you know, when women, so that's why counseling is very important. You tell them ahead. So when you're expecting something, when it comes, you are no longer baffled. It's not catching you unawares. As against when you're not told that, oh, you may experience this, you may experience slight headache, but it leaves after like 2 weeks, then you're better prepared for it and you can handle it, right? I'm on contraceptives, okay, because I'm done having kids. I have 3 of them and I'm fine. I have 12, 8, and 4. So I think I've also shown evidence that I'm not just an advocate of family planning, I also practice it. And I'm great, and I'm sure there are so many other women who can also come out, and it's part of what we also do. We have women who give testimonials, not like we coerce them. People can actually share, like I've been on contraceptives for this number of years. It's not my first time using it. You know, after my first kid, I had it. When I was ready for a second one, I took it out. I had my second child when I was ready for another one. And then I'm doing great. So when we have more of these testimonials, which we also bring up on our shows on radio, we bring up women, we interview them. They tell you, oh, yes, I experienced some bleeding, but I was told ahead that I would, you know, probably bleed. So she's prepared. It's not coming as a rude shock. And then it's gone after a few months, and I'm great. So thank you.
Okay.
All right.
And in addition to that, a minute, please, to clarify things. It's one of the lessons learned for Lafia Nigeria. That's the non-involvement of men from the onset of these services. And we are currently working on it and identifying partners that we can collaborate with, such as FEM, for sensitization and awareness creation. So this serves also as a good avenue for this collaboration. And going forward, I'm sure all those challenges will be addressed sequentially. Thank you.
Okay, thank you, the panelists, for these wonderful presentations. My question goes to Dr. Umar. When you were presenting, you made some highlights about some difficulties you are having in setting up the RUFT, that is ready to use therapeutic foods, and the challenges you have sourcing for the resources. But I want to bring you to a notice that can't you, in a way, alongside that, see how you can counsel the mothers on sourcing for locally available nutritional components for putting together this nutrition dense food like the F75 and the F100, like using enhanced pap mixed with proteins for these women, instead of you taking it upon yourself to mitigate this harm. And also, you can also counsel the women on how to prepare local ORS. I think it will lessen the burden on you and your organization than, trying to teach them directly on how to mitigate this problem. Because when they go back to their communities, they serve as source of advocates to other women that you cannot reach. And they can also teach these women on how to prepare this food instead of you trying to, directly interface with them. And my second question goes to Lafia. You said you use Cyanapres, which is a long-acting reversible contraceptives. And aside this, are there not other contraceptives that you can introduce to women that are on short-course contraceptives? And if you have, can you make known of them to us? Because we are also change of advocates. Thank you very much.
Yeah, are you itching? Yeah, so happy to go first. So I think in terms of the areas that we operate, so in the selection process, we select areas that the socio-economic status is quite bad. So it might interest you to know that in some of the households, some of them go without eating for days. So they don't even have stock of this food, whether soya beans, peanuts, or guinea corn, or millet that we prepare the tombram, with. I mean, it will be a good approach in areas where, communities are somewhat well-to-do and they have some of these, stocks at home. And we've, at some point, tried, a model which is very similar to what CRS does, Catholic, Relief Service. So what they do is that they go into. So what we did was we went into the community. We make a group of women and attach a team lead or a group leader. We instruct them to say bring these commodities in certain quantities, and then our staff will walk them through how to prepare this tombram, and they can go home with it. And we even bring scales to them, and we can make them we can prepare daily rations for them using the scales. But this doesn't happen in all the communities because some of the areas that we operate are quite bad. That people can't afford even to eat, which is quite strange.
Okay. Currently, as I mentioned, focus is just one method of contraception. That's DMPAST Cyanapres. And we chose that because we feel it's easily reversible, being effective for the period of 3 months. And where I mentioned 4 doses for a year, it's for those that require a long-term method, but also using Cyanapres can work. 4 doses in a year, that's the interval of 3 months. And it will also reduce the rate of visits for women who cannot access facilities easily, who live in hard-to-reach areas and deep down in rural areas. A woman can come once in a year, that's if she requires to do a long-term family child spacing. And if it's going to be for a short period, it's 3 months and easily reversible. Thank you.
Maybe just to add, I think, while Faisma was speaking, something came to mind, is that some of this, you see, even what LifeAid is trying to do is to reduce, the facility visits. So despite that, the services we even provide end-to-end at zero cost, for the caregivers at times to have 50 naira, 100 naira, to transport themselves to the facilities is a problem. So at times you even have to give like double ration just so that the caregivers can even afford to access the free service. So, I mean, in some of the communities, you have to visit them. It is quite bad.
Yes, I think one thing is Sayana Press self-injecting. So maybe you also need to understand, it's self-injecting. The women are taught to inject themselves. And that's why if you come once, you can get the 4 doses you need in a year, and you just need to know the spacing. After every 3 months, you self-inject yourself without having to go back to the hospital. But of course, there are other methods that last longer for 5 years, 10 years. You have 3 years, 5 years implants. Various methods of family planning.
Thank you. Can we give a round of applause to our panelists? Thank you so much. We've come to the end of the panel session.